You're dispatched to an adult male, uncontrolled nosebleed. There's no trauma reported, is the report. When you get on scene, you find the patient sitting upright on a couch, leaning forward. He's got an active anterior nasal bleeding, and he's bleeding into a towel. He's alert, anxious, and embarrassed more than panicked. His initial vitals are a heart rate of 104, blood pressure 198 over 110, respiratory rate of 20, it's at 98% on room air. He's warm, slightly diaphoretic. What are you anchoring on already? What catches your eye? Is it potentially the BP? That BP is going to be a problem. Are you worried about him stroking out? Are you considering how to lower this blood pressure? I'm Angry Bill. I've been a paramedic long enough to have made most of the mistakes you're trying to avoid. It's just a part of a series where I'll give you a scenario, describe a patient to you, and give you some time to think about some questions, some discussion points. And then I'll go over it right then. One of my biggest pet peeves is on social media where there's a great case or great x-ray or great whatever, and then I never see the answer, or I just got to wait for the answer. So here, pre-hospital wisdom, we're not doing that. I'm going to give you the answer, at least my answer, right now as we go at it. Let's make you harder to fool by bad medicine. What's your treatment priority? You can aggressively address the blood pressure. You can focus on hemorrhage control. You could just transport immediately without doing a whole lot. It's a nosebleed, he ain't gonna die. Or do a full assessment before touching anything. So the early problem, the common EMS problem that's starting to show up here is if you treat the blood pressure, treat the number instead of the problem. You don't want to treat the blood pressure, you want to treat the bleeding. Remember, you haven't even taken a history yet. How about we do that? He isn't dying right this very second. He doesn't need an intervention. Interventions are clearing an airway, starting CPR, quick tourniquet. Those are separate from treatments. Let's get information before we make treatment decisions. My answer to that would be get more information. So for history, he's 72. He's got a past medical history of AFib, hypertension, and hyperlipidemia. For medications, he takes apixaban, metoprolol, and lisinopril. He's got no allergies. His nose started bleeding spontaneously about 45 minutes ago. He says it happens sometimes, just never like this, never this bad. There's no trauma. There's no recent upper respiratory infection, no cocaine, no nasal sprays. The bleeding is continuous and not pulsatile. You now have epistaxis, a DOAC on board, severe hypertension, anxiety and sympathetic surge. So now let's talk about that decision point. What's causing what? Is this hypertension caused by the nosebleed? Is this a nosebleed caused by the hypertension? Is it caused by the anticoagulant? Is it all of the above or is it none of the above? So let's talk about the anticoagulants first. What the evidence actually says is that anticoagulants do not cause epistaxis, but they increase the severity, they increase the duration, they increase recurrence. DOACs, like apixaban, lower the risk of catastrophic bleeding have a lower risk of catastrophic bleeding than Coumadin, but they're still associated with increased mucosal bleeding. Most epistaxis originates from Kesselbach's plexus. It's a fragile superficial vasculature just inside the nose. The key point is that the anticoagulant didn't start the fire. It made the fire harder to put out. There's some citations on the screen in case you want that. So now let's talk about that hypertension. Is it a cause or is it associated? This is where EMS routinely gets it wrong. What hypertension doesn't do well, it doesn't reliably cause spontaneous epistaxis. There's weak evidence that elevated blood pressure alone ruptures nasal vessels. What it does correlate with is anxiety, pain, catecholamine surge, white coat response, fear of bleeding out. Patients get very upset at any amount of bleeding, even bleeding that you don't think is a big deal. They're holding it together, but inside their minds, they're panicking. Patients with epistaxis often present hypertensive. Treating the blood pressure, though, has been shown to not stop the bleeding. The blood pressure frequently normalizes after bleeding is controlled. So the translation of that is high blood pressure is usually a reaction, not the cause. It's not the trigger. So let's get this out of the way early. High blood pressure didn't cause this nosebleed. I know the number was ugly. 190s over 110s gets everyone attention. It feels like the thing you're supposed to fix. But here's the problem. Treating the blood pressure doesn't stop the bleeding. Stopping the bleeding will fix the blood pressure, though. Epistaxis is a local mechanical problem. There's fragile vessels, there's dry mucosa, and minor irritation, like the booger hooker. Anticoagulants don't start the bleed, but they refuse to let it quit. What does drive the blood pressure up? Anxiety, pain, watching yourself bleed for 45 minutes. EMS loves clean cause and effect stories. The blood pressure's high, the vessel must have popped. No, it doesn't work like that. It's simple, it's comfortable, and it's usually wrong. The evidence keeps saying the same thing. Hypertension shows up with epistaxis, not reliably before it. Correlation is not causation. We all learn that in school. Then we forget it in the bus. Here's the quiet trap. You see a scary number. You reach for a big intervention. Meanwhile, the actual problem keeps bleeding. Direct pressure, vasoconstrictor, reassurance. Recheck their blood pressure after you do your job. If the pressure comes down once the bleeding stops, that wasn't a hypertensive urgency. That was physiology doing exactly what it's supposed to do when a patient's fearful. Stop fearing those numbers. So let's talk about management options. There's some reasonable paths with some pitfalls. You can treat the blood pressure. This sounds proactive, it sounds aggressive, but it doesn't address the bleeding source. Risk of hypotension once the anxiety resolves, and there's no evidence it improves the epistaxis outcomes. We could withhold care because it's just a nosebleed. Nosebleeds are indeed often benign, but this patient is anticoagulated with prolonged bleeding. It's not necessarily benign. This also underestimates the cumulative blood loss. Finally, we could focus on local hemorrhage control with direct pressure, properly applied and uninterrupted. We can use a topical vasoconstrictor like neosynephrine sprays. We can lean the patient forward, not supine, and consider a TXA-soaked pledget if you're allowed to do that. Mostly, we're going to reassure them to see if the BP can improve once the sympathetic tone improves. So that's the grown-up answer. Deal with the nosebleed. So some cognitive traps to watch out for is anchoring bias. That BP is dangerously high. Everything revolves around that. Protocol fixation, treating epistaxis like a vitals problem instead of a bleeding problem. Commission bias, feeling the medic needs to do something big instead of something effective. And then medication blame is over-attributing causality to anticoagulants. Don't fall for that stuff. Let me explain how I deal with epistaxis. I pinch the nose. It's that simple. But it has to go for at least 5 minutes, preferably 10. And if the patient's been bleeding for a while, partial clots can form that aren't stopping the bleeding, but can interfere with direct pressure. So I can have the patient blow their nose. It's going to be a mess. I've seen clots like black forearm length leeches coming out. That is a good thing. It's gross as hell, but it's a good thing. A squirt of neosynephrine up the nose can constrict the bleeding veins, but be thoughtful about that if the patient's hypertensive. It is neosynephrine after all. Then the nose clamp. You can use fingers, but I get bored. Don't trust the patient to do it. Even if you set an alarm, they'll want to be checking in 30 seconds. It's important. No peeking once you're set up for at least 5, preferably 10 minutes. If you peek, you get more forearm clot leeches, and you got to restart your timer. So set an alarm and no peeking. So back to our case. After 15 minutes of proper management, as described, the bleeding seems to have stopped. The patient's visibly calmer and a repeat blood pressure is 168/96, heart rate of 88, and no antihypertensives have been needed. So the best clinical interpretation, the most likely interpretation, is that fragile anterior nasal vasculature begins bleeding. Dry air and nose picking are part of the cause. Anticoagulation prolongs hemorrhage. Anxiety and blood loss leads to sympathetic surge, leads to hypertension. Blood pressure elevation is often correlative, not causative. The best approach is to control the bleeding first. Treat the patient, not the monitor. Treat the patient, not the sphygmomanometer. Transport for evaluation, the patient is actually anticoagulated and stuff like that. There has been prolonged bleeding. There's age and comorbidities. For the final teaching pearl, if lowering the blood pressure doesn't stop the bleeding, maybe the blood pressure wasn't the problem. Before you take off, thanks for spending a few minutes with me. I'm Angry Bill, and this is Pre-Hospital Wisdom. If this helped your thinking, challenged a habit, or gave you something you'll actually use on shift, do me a favor. Hit like, subscribe, and share it with someone who could use better information as well. That supports what keeps this channel focused on making clinicians sharper, calmer, and harder to fool by bad medicine. I appreciate your time more than you know. And until next time, don't worry about the number.